Do you know that actually we can change undesirable behavior to our target behavior? Do you also know that people who has negative behavior can change to a person who has a positive behavior? So, this is the use of behavior modification.
Introducing our speaker, Nur HAFIZA binti Ahmad, with number matric A170652, Nur NAJWA binti HUSSEIN, A169853, and Arifah binti Yusri, A170211.
Have you ever met or watched the movies that portray someone who frequently shrugging his shoulder or saying the same word repetitively until it annoys people surrounding him? We call it as Tourette syndrome. What is Tourette syndrome? Tourette syndrome is a neurodevelopmental condition that causes involuntary motor tics and vocal tics for over than a year. Motor tics are the movements of the body, such as eye blinking, shoulder shrugging, or jerking an arm, while vocal tics are the sounds that a person makes with his voice, including humming, throat clearing, yelling out a word, or saying the same word for a few times. People who have tics cannot stop their body from doing these things. The first onset of Tourette syndrome is at the age of 5 to 7 years old, and the tics usually become worse when they are in stressful situations and tend to improve when a person is calm or focused on an activity. There are 4 types of tics: simple physical tics, simple phonic tics, complex physical tics, and complex phonic tics. Simple physical tics such as blinking eyes and stamping head, while simple phonic tics include coughing and shouting. Complex physical tics will make them kicking things, jumping, and knock on things. And complex phonic tic is referring to echolalia, echoprasia, and coprolalia. Echolalia is the unsolicited repetition of vocalizations made by another person, or the meaningless repetition of another person's spoken words as a symptom of psychiatric disorder. Next, echoprasia is a mechanical repetition of another person's movements or gestures, and coprolalia is an involuntary swearing or the involuntary utterance of obscene words or socially inappropriate. The one that having this Tourette syndrome usually will having a difficulty in social life, such as get bullied by others, academic and work performance decrease, and also low and in quality of life. To avoid all these things getting worse, people who suffer from this disease needs to get behavior modification. The first treatment that we can use to treat Tourette syndrome patient is by using habit reversal treatment, HTR. HTR is a multi-component behavioral treatment technique that was initially used to treat a variety of repetitive behaviors, including treating tic disorders such as motor tic and vocal tic. HTR is often widely used to treat tic disorders, and this technique has effectiveness in reducing tic motor and vocal disorders. In addition to treating tics, HTR can also treat trichotillomania, nail biting, and stuttering. In general, HTR consists of awareness technique, competitive response training, contingency management, relaxation training, and generalization training. A study was conducted by Woods and Lucely 2007 in a clinical setting on a boy with tic disorder. A 10-year-old boy named Joe, who has been diagnosed with Tourette syndrome but has not confirmed that Joe has a comorbidities of other psychiatric disorders. Although Joe has a normal level of intelligence and has age-appropriate language skills, Joe suffers suffers from severe stuttering for verbal communication. The treatment conducted on Joe consisted of 4 phases, namely awareness technique, self-monitoring, and competitive response training combined with a relaxation exercise or a relaxation training. At the beginning of the treatment procedure, during the beginning of the baseline phase, Joe was prescribed clonidine. The habit reversal training applied to Joe had 4 phases, namely awareness techniques, self-monitoring, relaxation training, and competitive response training. Prior to the full treatment that took 20 weeks, Joe's mother was tasked with being an observer and recording data for the duration of the baseline phase at home. The first phase is awareness training to increase Joe's awareness in relation to the tic disorders Joe is facing. During this phase, the therapist helps Joe to identify, describe, and produce dominant vocal disturbances and motor tics known as response descriptions. Conversations between Joe and the therapist were also recorded and evaluated to help increase Joe's awareness of vocal tics and define each tic's behaviors accurately. At the same time, Joe observes the therapist modeling the motor disorder tics. In addition, the therapist also tracks Joe's reaction each time he shows certain tics by signaling to Joe. Next, over a randomly selected 5 minutes period during this training, Joe and the therapist recorded the frequency of tics performed by Joe, and such were analyzed and discussed until the reliability between them was 90% or more. Therapists also pay more attention to vocal and motor tics, focusing on situational data collection at home. Joe underwent awareness training alone for 4 weeks within a randomly selected 5-minute period. During this training, Joe and the therapist recorded the frequency of tic performance by Joe, and such were analyzed and discussed until the reliability between them was 90% or more. Therapists also pay more attention to vocal and motor tics, focusing on situational data collection at home. Joe underwent awareness training alone for 4 weeks within a randomly set 5-minute period. During this exercise, Joe and the therapist recorded the frequency of tic performed by Joe, and such were analyzed and discussed until the reliability between them was 90%. The second phase of self-monitoring begins after Joe completes awareness training. This phase is performed outside of session time with the therapist by performing the same activities during awareness training and carried out throughout the HRT treatment. The frequency of tics by Joe is a given period that Joe had chosen was recorded using a special form that his mother had modified as appropriate. The data collected was monitored by the therapist during a self-monitoring session. Next, the data were used to isolate situations and circumstances related to the increase in tic frequency by Joe. However, there were 2 weeks Joe and his mother did not record awareness training due to having health problems. Data were recorded for the self-monitoring phase with awareness training for 4 weeks. The third phase is relaxation training, conducted after successfully completing the second phase. For this third phase, Joe underwent relaxation training along with successfully completed awareness and self-monitoring training. During this phase, the therapist taught Joe several calming techniques such as a progressive muscle relaxation, deep breathing exercise, and soothing self-expression, as well as doing stretching yoga movements. Stretching with a combination of relaxation is a relaxation technique that can calm Joe even outside of the therapy session time with the therapist. Joe needs to undergo relaxation exercises every day for about 10 to 50 minutes with help of his mother. The third phase is relaxation training conducted after successfully completing the second phase. For this third phase, Joe underwent relaxation training along with successfully completed awareness and self-monitoring training. During this phase, the therapist taught Joe several calming techniques such as progressive muscle relaxation, deep breathing exercise, and soothing self-expression, as well as doing stretching yoga movements. Stretching with a combination of relaxation is a relaxation technique that can calm Joe even outside of the therapy session time with the therapist. Joe needs to undergo relaxation exercises every day for about 10 to 15 minutes with the help of his mother. He underwent relaxation training well on the basis of control. Therefore, each experiencing an increase in tic frequency anxiety, Joe needs to use relaxation exercise that he is comfortable with. After 4 weeks of Joe undergoing training in this phase, Joe's treatment moved on to the next phase. The fourth phase is competitive response training, in which the therapist teach Joe to perform behaviors that are contrary to the topography of the tic. This phase runs safely for 3 weeks. This phase also involves awareness training, self-monitoring, relaxation training, and competitive response training before concluding the HRT treatment session. Since Joe shows a vocal tic, then the target competing response is slow and uses deep breathing through his nostrils. In addition, Joe was also taught to express by uttering statements to calm himself and slow down the pace of his speech simultaneously with competing responses. However, tic motor disorders involve less eye, face, and neck muscles. Competitive response that have rhythm as well as controlled blinking in a 2-second schedule. The neck stretching exercises learned during the relaxation training phase are the opposite of head jerks and the facial grunts, for which it is useful for the fourth phase. Joe reported he could practice movements based on control cues and acquired additional control to aid tic motor control. The therapist analyzed each treatment session collected whether in the presence of competing responses or not. This is to confirm the effectiveness of the exercises for tic disorders. Results from the treatment showed that there was a gradually and steady decrease in vocal and motor tic. Motor tic vowels were pronounced compared to motor tic, with an average of 60 times per 5 minutes during the baseline phase. During the awareness training phase, vocal tic was recorded 37 times for 5 minutes. The tic vowel frequently rate decreased with the phase transition and was eliminated over the last 3 weeks. The frequency of motor tics decreased and stabilized from the baseline phase up to the third phase, and the frequency approached the blank level at the end of the training treatment. During the follow-up treatment given to Joe, the tic disorders that occur to Joe diminished. On average, the frequency for the tic vowel occurred 4 times for a period of 5 minutes, while the frequency for the motor tic occurred 1.5 times for a period of 5 times. Additionally, this treatment did not affect the stuttering Joe faced. Overall, HRT is a technique that can be used to reduce tic disorders in people with Tourette syndrome.
The article is Relaxation Therapy as a Treatment for Tics in Patients with Tourette Syndrome by Florence Trilling and Andrea E. Cavana. Relaxation therapy that used in behavioral therapy as one of the ways to reduce anxiety, tension, and stress, especially on certain phobias such as Tourette syndrome. RT is divided into two types in this case study. First, comprehensive behavioral intervention reversal habits training. Second, treatment intervention in various components. There are two steps to complete RT. First is deep breathing technique. This technique intended to restabilize the respiratory system and regain oxygen. Second, progressive muscle relaxation exercises. It is to involve muscle tension to make us more calm and in control. So, the result of these studies, 4 over 7 single cases have been effective using RT for use in treatment of Tourette syndrome. RT is also certified safe and effective as one of the behavioral treatment methods in Tourette syndrome, and the effectiveness also can be seen in a short term.
The third behavioral treatment is to reduce the repetitive behavior that associate to Tourette syndrome, and the treatment is the exposure and response prevention (ERP). ERP it consists of repeated prologue to stimuli that elicit discomfort and instruction to refrain any behavior that serve to reduce discomfort. And this treatment is aimed to reduce the repetitive behavior that were evening up, symmetry, and arranging. And in this case study, the therapist used a multiple baseline to evaluate the intervention. The procedure treatment consists 3 phases, which were the first is behavioral exposure test, the second is treatment, and the third is inter-observer agreement. For the first phase, which is behavioral exposure test, is used for 3 behaviors were composed of the situation in each hierarchy most likely to elicit the behavior. Each procedure administered for 5 minutes, and each minute the patient must rate the subjective unit of discomfort scale, or SUDS, from 0 to 10, and the frequency of the completing the target behavior. And this test was took in the home setting. The second phase in ERP is treatment, and it took in clinic setting. Before, in behavioral exposure test, the patient was already exposed to the situation that elicit the behavior. So in this phase, the patient given a verbal reminder to resist behavior if he made attempt to contact the object in eliciting situation. And the therapist also could have used the physical prompt, such as gently guiding his hand away from the target behavior. It took around maximum 20 minutes, and it will complete after the patient rate the SUDS, and also the patient practice at home daily. For the third phase is inter-observer agreement between first author and independent observer. Along the phase 1 and phase 2, they are recorded by videotape. So the independent observer listen to the recording. The agreement outcome for overall is 100%, which were for the evening up is 100%, for arranging is 100%, and for symmetry is 92%. The result of the treatment show the repetitive behavior and associate self-report distress were eliminated. But after 3-month follow-up, the frequency of 2 behavior, which were evening up and arranging, returned to the baseline level. Ladies and gentlemen, so we conclude there are various behavioral treatment that we can use for Tourette syndrome. There are, and the first is habit reversal treatment. Second is the relaxation training, and the third is the exposure and response prevention. But we also have another one as additional relaxation training, and the third is the exposure and response prevention. But we also have another one as additional treatment called maze practice, which is we can combine it with any suitable main treatment. So please keep in mind that it's very important for us to use the right treatment to control and reduce tick distraction.
Now, have you ever heard someone who is really afraid of blood and injection? We categorize it as someone who is suffering from the blood injury injection phobia.
So the next topic, we will discuss about blood injection injury phobia or BII phobia and its treatment. So what's a blood injection injury phobia? Actually, it's one of the specific phobia that has a persistent irrational fear of needle, injection, or injury that relates to any situation or viewing of blood, injection, or wound or deformities. It is a common psychiatric disorder with an estimate around 3% to 4% in general population. Individuals with this phobia may show vasovagoration or deficit cardiovascular during injection, and it will lead patient to faint. And in a worldwide clinical treatment, this phobia usually treated by cognitive behavior therapy, applied relaxation, and applied tension. But in this video, we will share what is the behavioral therapy that we can apply for BII phobia patient. So let's move to the treatment. Exposure and participant modeling. It used to treat the injection phobia patient. In literature, there are two types of the injection phobia. The first type is vasovagal type, which is sometimes will show cardiovascularization during injection, and sometimes you will react passively. And the second type is resistant type, which is have a strong and sometimes will react violently during injection and have no vasovagal reaction. This therapy will expose patients to the relevant situation related to injection, and the patient need to participate to practice modeling that module by the therapist. In these therapies, there are 4 phases. The phase 1 is treatment procedure. In this phase, patient will instructed to the progressive muscle injection for 2 weeks to practice, and then the patient needs to rate 0 to 10 scale for an anxiety hierarchy scene. For the next phase, session 1 is exposure and response modeling. It takes around 3 hours in this session. First, the physician will expose the hierarchy situation and scene to the patient, alternating with relaxation procedure. The relaxation procedure was applied to the patient before. Next, the patient also exposed to the subcutaneous injection, and the patient needs to react, need to respond for every single injection and situation that they are exposed. Along the session of the therapy, from session 1 until session 3, the heart rate of the patient will record, and also her state anxiety. Then the second session is self-injection. It takes around 2.5 hours for the session. Before, it is exposure and response modeling, and it alternated to participant modeling in this session, and it depends on the success of each step before proceeding to the next step. In this session, the physician inject the patient based on what they demonstrated before at the first session. At first, the patient refused to the injection, but after a few attempts, the physician success to inject her by using passive movement. Passive movement is a string move slowly before inject into the skin, and this is suggested by the patient. The last session is injection and venipuncture. This session always consisted of the repetition of the following procedure using a response modeling paradigm for two situations. The first situation was being injected by the physician, and the second situation was blood drawing by the physician. Both procedure reported performed well without any difficulty by the patient, but her heart rate increased and it takes 3.5 minutes to calm down. The patient had a second type of injection phobia, which was the resistant type. So this therapy effective in eliminating the fear of injection. After a month follow-up, the patient had a blood draw and it reportedly he can draw it without any difficulty.
Blood injury injection phobia also can be treated by using combined applied tension treatment and diaphragmatic breathing. Rahman Mueller et al. 2018 conducted a study entitled Large Group 1 Session Treatment or LGOST, a feasibility study of exposure combined with applied tension or diaphragmatic breathing in highly blood injury injection of fearful individuals in 2018. This study combined applied tension treatment and diaphragmatic breathing methods on individuals suffering from blood injury injection phobia as one of the ways to cope with their fear of needles. Participants involved in this study were a total of 40 people who were in the category of highly afraid of blood injury injection. Participants for this study were obtained through advertisement on local radio, newspapers, social media, and also on designated websites. And the condition to involve in this research is the individual must have a very high level of fear of blood or any injuries or injections, as well as always avoid situations involving blood collection. They were also instructed to answer the multidimensional blood or injury phobia inventory (MBPIK) test tool online to ensure they were eligible to be part of the study. Participants' fear were measured using MBPIK, and this treatment also involved the Behavioral Approach Test (BAT) method as a test to identify their phobia level before and after receiving treatment. The stability of treatment effects was monitored through an online survey over the next 7 months. BAT was performed on the participant before and after the treatment was held. There are 8 steps that need to be followed. Firstly, they need to enter the treatment room, which is where the blood is withdrawn. Second, the participants are required to sit on chairs with their sleeves rolled up. Third, the participants need to allow a medical professional to install standard tourniquet that used to tighten upper arm that can ease the blood withdrawal. The fourth step, participants need to allow the medical professional to place a cannula and a blood tube next to them. Next, the fifth step, they also need to allow the medical officer to open the needle package. Step 6. Participants is then allowed the medical officer to place the needle in the position it had been estimated to be injected. The second last step, they have to allow the medical officer to take a blood sample, and lastly, they are required to see the blood flowing into the cannula. When each of these steps was taken, participants were required to assess their subjective distress and disgust intensity on a scale of 0 to 10. Steps 1 to 6 will be performed before treatment, while steps 7 to 8 will be performed after treatment. LG treatment involves several phases, including the training phase and the exposure phase. The training phase is divided into 2 parts, namely diaphragmatic breathing training and applied tension training. This training is taught by clinical psychological therapists who are experienced in treating phobias. This diaphragmatic breathing exercise was conducted for 20 minutes, and participants were instructed to pay attention to deep and soothing breathing. This training is given so that they are able to apply it when faced with real fear. As for the pressure application training, participants were instructed to tense the legs and gluteal muscles for 15 to 20 minutes intermittently. After 20 seconds of the recovery phase, participants were asked to tense their arms and hand muscles. Next is the exposure phase. There are 3 types of exposure that will be given to participants. Among them are exposure to pictures that can invite phobias, video exposures, and live exposure. During phobia picture exposure, relevant pictures such as injuries, blood drawings, and injection were displayed to the patient for 60 seconds for each picture. Afterwards, the psychotherapist showed a video of the blood drawing procedure and the detailed sensation experience so that they were also felt by the listening participants. Furthermore, for direct exposure, participants were required to witness firsthand the process of a volunteer taking blood by a medical officer. Individuals who volunteer are patients who have undergone BAT treatment. Next, participants were required to answer the German test which had been translated into English, which is Blood Injury Injection Fear Questionnaire by Vobek Elsbach et al. In 2012. This test contained 20 questions measuring BII subjective fears using a measurement scale of 1, which is not at all, until 7, which is tremendously struck. The second test tool was the Multilation Questionnaire MQ by Rahman et al. 1974. This test tool contains 30 questions with a choice of yes or no answers, which measure the degree of avoidance of wounds. Next is the Multidimensional Blood Injury Phobia Inventory MBPI by Geffard et al. In 2010. This test tool contains 14 items that measure the cognitive, behavioral, and emotional aspects of a person with BII fears. They were required to assess the symptoms experienced during the occurrence of a BII-related situation on a scale of 0, which is never, to 4, which is always. As a result of this study, as many as 80%, which is equivalent to 32 study participants, showed a level of fear exceeding the minimum score, which is 67 in the current BVSF before treatment was carried out. Meanwhile, after the treatment, only 50% was equivalent to 20 participants who still experienced the same fear. In contrast, 4 participants showed increased levels of fear in the BVSF test. As for the MBPI test, 90% equivalent to 36 participants initially showed a level of fear above the minimum score of 48. After the treatment, only 60% equivalent to 24 participants who are still at the same level. However, only 1 participant experienced improvement after treatment with a change of only 1 point. Furthermore, for the BAT method, a total of 22 participants, 55%, had a history of fainting during the blood collection process. After undergoing BAT, as many as 70% of the 28 participants were able to undergo the process out of a total of 15 people who had a history of fainting, while another 45% are able to see the process of taking blood closely. Compared to the pre-treatment period test, 2 participants showed less behavioral approach on the last 2 steps of BAT after treatment.
I will present regarding an article that titled Self-Arranged Exposure for Overcoming Blood Injection Injury Phobia, a case study from Michelle R. Pitkin and John M. Malouf. BII phobia is an acute fear and avoidance of stimuli or invasive medical procedures associated with blood, injection, and injury by Litterscoot, Josephine, and Saizo on 2010. BII can be so dangerous because sometimes it is leading to faint or any kind of injuries. Usually, this kind of phobia was happen for those that scared to get any kind of injections, whether in blood donation or hospital treatment. So, what is another kind of behavioral treatment for this phobia? It is self-arranged exposure. What is it? Self-arranged exposure is a muscle tension that can prevent a person from fainting. So, how does it happen? First, the patient needs to tense the muscle, arms, legs, and body for 15 to 20 seconds. Second, and they will get back to normal for 20 seconds too. Third, they need to do this kind of action for 5 times. In this context also, systolic blood pressure and diastolic blood pressure in a single session were recorded. According to this treatment, subjective unit of the difficulty scale SUDS will be given to the patient. So, what is the function of SUDS? SUDS is a scale that representing patient's hierarchy of fear that starting from 0 represent not fear till 100 represent extremely fear. The result is, after the patient treated by self-arranged exposure, they can begin to be able to donate blood and use this method before receiving any kind of injection to avoid fainting. In conclusion, there are various of behavioral treatment for blood injection injury phobia. There are 1. Pressure application treatment method and drug-formatic LGRST. 2. Self-arranged exposure. 3. Exposure and modeling method and technique. This is important to ensure they are no longer afraid of any kind of injections.
We hope all the knowledge that we share can help you guys in the future. That's all from us. Thank you and Assalamualaikum.